Hi everyone, welcome to my podcast. I'm Dr. Kash Gupta. I'm a gastroenterologist and hepatologist here in the UK. And I've trained in various institutions, including University College London, Royal Free Hospital, Oxford, Cambridge University Hospitals, where I did some transplant training, and Harvard Medical School, where I did the majority of my research. Today I wanted to talk about alcohol and mortality, which is a very emotional topic because it involves a lot of illness and a lot of emotion around people that surround the alcoholics. And more specifically, we see a lot of people die from alcohol-related liver disease, unfortunately. And those people can be quite young, in their 20s or 30s. Going up to old age, but the average death is around 50 to 55. And it's really sad to see, because when you see someone really sick from alcohol and the liver failing, what I tell relatives is we don't really have an effective dialysis equivalent like we do for the kidneys. And people end up dying, unfortunately. If you can't replace the liver, then people may unfortunately die. And it's emotional when I have to talk to the relatives and just explaining that. A lot of the time they're aware, but you talk to kids, the kids of patients, sometimes young kids, and parents. You know, being a parent, watching your child die, even if they are an adult, brothers and sisters, there's too many. I can think of a lot of stories, and there's too many to talk about in this podcast episode. But suffice to say, we have a real problem in the UK. And this topic, when I talk about it, it's not just about those people listening on how or why we shouldn't be drinking or reducing alcohol intake massively, but also for people to take that information away and spread it and see if they spot it amongst people that they know and love. I certainly am a real downer at family parties. I see, people drinking, and I try and politely explain why it's probably not a good idea, maybe try something else. So I'm a real party pooper, but I think it's important to keep pressing on with this. My confession is that for years, through medical school, training at Oxford and Cambridge, and working in transplant units, even after all of that, there were long periods of time where, when you talk about alcohol in general, the information I was probably giving was not quite right, and potentially harmful for some people if they were drinking when they had other coexisting liver disease. And at the time, it was, fair enough, because I would quote things like the French paradox, where we would see back in the 2000s, I think it was, the French lower their risk of ischemic heart disease, or so we thought, by drinking red wine. And people who had a Mediterranean diet, they would drink a little bit and still live quite long. And the data was textbook at the time, where you had a J-shaped curve with mortality, the amount of alcohol you drink, where the people that drink the least were over here, and then the least risky were the people that drank moderately, and then the most risky were the people that drank the most. And study after study showed that teetotalers were at slightly higher risk of death than the moderate drinkers. But the thing about these academic papers, these textbooks, they get rewritten. New research comes out. And in the past few years, we've had bigger cohorts of patients, studies, and different methodologies, and even genetic studies, which have cut through that noise. And it's forced us to reassess how we talk to patients about alcohol. And a lot of doctors still don't do that. They use the old paradigm. But I want to talk you through what changed my mind a number of years ago. And we're going to look at about 5 different papers nearly 5 million participants, hundreds of thousands of deaths tracked, and a genetic technique called Mendelian randomisation that essentially runs a natural experiment on human populations. And so by the end of the episode, you'll understand why the old slogan, "A drink a day keeps the doctor away," needs a rewrite. So let's start with the picture that's been in our heads for decades, the J-shaped curve. If you've ever Googled, "Is alcohol good for you?" you've probably seen some version of this graph. On the x-axis, you have alcohol consumption from 0 drinks to heavy drinking. On the y-axis, you've got mortality risk. And the curve dips down for light to moderate drinkers before climbing steeply for heavy drinkers. And so the implication to that is quite seductive. Don't drink at all, and you're actually at higher risk than someone who has a glass of wine or 2 at dinner. And that is what I grew up being told. And it wasn't fringe science. It was published in major journals, replicated in multiple populations, and became the basis for public health messaging in many countries. It reminds me of how smoking was good for you in the 60s. And so anyway, what did they find? Exactly what you'd expect from the traditional model. Current light and moderate drinkers had hazard ratios of 0.77 to 0.87 compared to lifetime abstainers. So that's a 13 to 23% reduction in all-cause mortality. Heavy drinkers, unsurprisingly, did worse with higher mortality from cancer, cardiovascular disease, and unintentional injuries. So if you stopped reading there, and many people did, including many physicians, the message was clear. Moderate drinking is protective, maybe even helpful. But here's where it gets interesting, because 3 of the papers I'll talk about show you why that's really shaky ground. So 2016, team led by Tim Stockwell published a really good meta-analysis in the Journal of Studies on Alcohol and Drugs. And we kind of needed this. They didn't just pull the data from existing studies. They interrogated the methodology. They looked at 87 cohorts of studies, nearly 4 million participants, about 387 deaths. And they asked a simple but devastating question: who exactly is in the abstainer group that moderate drinkers are being compared to? And what they found changed everything. So here's the first problem. Many of the studies lumped former drinkers into the abstainer category. Think about who the former drinkers often are. They're people who quit because they've developed health problems. Every time a patient gets admitted with alcohol-related liver problems, and I ask them, when did you stop drinking? They always give me the date of when they were admitted, because they were too unwell to drink, or just before, a week or 2 before they got admitted, because they're too unwell. And so people who quit, they often quit because they had liver disease, heart condition problems, cancers, and they're told by the doctors to stop drinking. So these aren't healthy abstainers. They're sick quitters, is what we call them. And when you include them in your reference group, you artificially inflate the mortality rate of abstainers, making moderate drinkers look healthier by comparison. So in Stockwell's analysis, former drinkers had a relative risk of about 1.22 compared to true lifetime abstainers. They were dying at substantially higher rates. And when you separate them out properly, the apparent benefit of moderate drinkers shrinks massively. Second problem, many studies classified people as abstainers, even if they reported occasional drinking. So someone who has a glass of champagne at weddings twice a year would be coded as a non-drinker in some data sets. So why does that matter? Because occasional drinkers tend to be healthier than true abstainers for reasons that have nothing to do with alcohol. They're more likely to be socially connected, economically comfortable, healthy enough to participate in celebrations. So they're a healthier group of people, not because of alcohol, because of they're richer. They've got other resources. And so the third and most important is the lifestyle confounding. So moderate drinkers systematically differ from abstainers in ways that protect health independent of alcohol. They tend to have higher incomes, better education, more access to healthcare. They exercise more. They eat better diets. They have richer social lives and connections. So when Stockwell's team adjusted for all these biases, separating out sick quitters, excluding occasional drinkers from the abstainer group, controlling for study quality, that magic of moderation essentially evaporated. And so the fully adjusted relative risk for low volume drinkers versus true lifetime abstainers was 0.97. So in plain English, statistically indistinguishable from no effect at all. So the J-shaped curve wasn't measuring health effects of alcohol. It was measuring the health effects of being the kind of person who drinks moderately in Western society. So now you might be thinking, well, that was 2016, maybe newer studies vindicated moderate drinking, but actually the opposites happened. So in March 23, Zhao and colleagues published, and I like this one, a massive meta-analysis in JAMA Network Open, and it was a really comprehensive analysis of alcohol mortality. 107 cohort studies, nearly 4.8 million participants, over 425,000 deaths, and critically, they applied all the methodological lessons learned from the previous decade. So in the raw, unadjusted data, the familiar J-shaped appeared. So low volume drinkers, people consuming between 1 and 24 grams of alcohol per day, roughly 1 to 2 drinks, seem to have lower mortality than abstainers. So for the UK guys, 1 to 2 drinks, we're looking at 2 to 4 units, maybe about 3 units. But then they started controlling for things like age, sex, country, follow-up duration, whether former drinkers were properly separated or not, whether occasional drinkers were misclassified, whether the studies controlled for smoking, socioeconomic status, diet, exercise, BMI, baseline health. And as each adjustment was applied, the protective effect just went. So in the fully adjusted models, occasional and low volume drinkers no longer showed a statistically significant reduction in mortality. The relative risk was around 0.93 to 0.96, and confidence intervals crossed 1. So that essentially means you cannot exclude the possibility that the true effect is 0. So the effect could be 0. Meanwhile, the harms of heavier drinking were just clearer and robust in every adjustment. So at 45 to 64 grams per day, roughly 3 to 4 drinks, relative risk jumped to 1.19. And at 65 grams, it went to 1.35. So we're talking, 4 drinks, it's, significantly higher, 3 or 4 drinks, 4 drinks. And so there's another finding of this paper that I think is particularly important for women, is that there's a dose-response relationship was steeper for women than for men. So women showed significantly increased mortality starting at just 25 grams, so about 2 drinks. For men, significant increase began at 45 grams, so about 3 to 4 drinks. So this isn't about being cautious or conservative. This is what happens when you look at the science in a different way. So now everything I've shown you so far is observational. And in medicine, we know that observational studies, tend not to prove causation. You can infer causation if the association is very strong, kind of like we do for smoking. But the gold standard would be a randomized control trial. So randomly assign people to drink different amounts for decades and see who dies first. But that's obviously unethical and impractical. People aren't going to do that. That kind of study would get stopped. So how do we get closer to causation? Well, this is where the most exciting development in alcohol research comes in. I say the most exciting. It's an exciting study. Mendelian randomization. So your genes are assigned to you randomly at conception. They're not influenced by your income, your education, your diet, exercise, lifestyle factors, anything like that. Those things confound these observational studies. Your genes are like a natural lottery. So they are random. So if we know certain genetic variants affect how much people tend to drink, some variants make alcohol metabolism unpleasant. So think of the Asian population, East Asian population, that get flushing when they drink alcohol. People with these variants drink less, not because of any health choice, but because of biology. So if we were to compare mortality outcomes between people with genes that predispose them to drink more versus less, we can estimate the causal effect of alcohol free from all the lifestyle confounding factors that plague observational studies. So in 2024, Casau and colleagues published exactly this kind of analysis in the International Journal of Epidemiology. They used data from approximately 278,000 white British participants in the UK Biobank with a median follow-up of 12.6 years, and they looked at around 20,000 deaths. And they identified 94 genetic variants associated with habitual alcohol intake. So first they ran a conventional observational analysis within the same data set, and sure enough, they saw the J-shaped curve appear. Light drinkers looked like they had the lowest mortality. They then ran the Mendelian randomisation, and the J-shaped curve vanished completely. Instead, they found a linear dose-dependent relationship. And for each additional UK unit of alcohol per day, that's about 8 grams, roughly 3/4 of a standard drink, the odds of dying increased by approximately 27%. Cardiovascular mortality increased by about 30% per unit. Cancer mortality went up by 20%. Any digestive, I think they mean liver disease here, digestive mortality increased by 106%, which it's mostly going to be liver cirrhosis and liver failure. So they tested specifically for non-linearity, looking for any evidence that protective dips at low doses, and the statistic came back with a p-value of 0.21. So that's not significant. That's not a significant p-value. So no evidence of a J-shaped curve. The best fitting model was actually a straight line. So dose-dependent relationship with alcohol. So more alcohol, more death. And this, in my view, is very important in the whole debate because it doesn't rely on trusting people's self-reported drinking habits. It doesn't depend on perfectly separating former drinkers from lifetime abstainers. It uses the fundamental randomness of genetic inheritance to cut through the noise. And the message is stark. There's no safe sweet spot. Risk climbs steadily with each additional drink. Now, I want to try and be fair because the picture isn't entirely one-sided. Study in 2022, Zong and colleagues published an umbrella review in Frontiers in Public Health, and essentially a review of reviews. So they looked at 59 publications containing 224 meta-analyses across 140 different health outcomes. And yes, they found some protective associations. Low to moderate alcohol consumption was linked with decreased risk of renal cancer, dementia, colorectal cancer, mortality. And in people with hypertension specifically, there was high quality evidence for reduced cardiovascular disease and all-cause mortality at moderate intake. But here's what's crucial. They also graded the quality of evidence for each association, and the vast majority of those protective effects were rated as moderate or weak quality, reflecting concerns about bias, heterogeneity between studies, and small study effects. Meanwhile, the harms were more consistent, more robust, and things like increased skin cancer risk at moderate intake, increased hemorrhage risk at high intake. Those reached high quality evidence. So the takeaway from the umbrella review essentially aligns with the theory that protective associations are narrow, population specific, and less certain, whereas the harms are at higher levels but clearer. Practical takeaways are that, if I gave you a bottom line on all 5 papers, the first thing I'd say is drinking is unambiguously harmful. This is consistent across every single study, every methodology, every population. If you're regularly consuming more than 3 drinks a day or engaging in binge drinking patterns, you are measurably shortening your lifespan. Full stop. Second, the supposed benefits of moderate drinking are much weaker than we thought. And they don't seem to exist at all if you look at the last few papers. And once you properly account for who's in the abstainer group, control for lifestyle confounding factors, use genetic methods to establish causation, the protective J-shaped curve shrinks or disappears entirely. Number 3, if you don't drink, there's no good reason, or not a good health reason to start drinking. So none of these papers support initiating alcohol consumption for longevity. So yeah, don't think that, you know, a little bit of alcohol is going to be good for you. Fourthly, if you do drink, less is almost certainly better. The genetic evidence suggests harm increases linearly with consumption. So every unit or, you know, amount that you drink less is better for you. Fifthly, important, women don't do as well with alcohol, and they seem to be put in a higher risk category. So the dose-dependent relationship starts earlier in women. 2 drinks, and you've increased your risk. Sixth, any decision about changing your drinking habits should be made individually with a healthcare professional, especially if you have existing health conditions or concerns about alcohol use disorder. Very important comment here. You know, people that don't think they're alcoholics, but actually are, and they're dependent on it, physically dependent on it, addicted to it, you have to get help to come down off it. And you have to come off it gradually, because there are complications, electrolyte disturbances that can be very serious, neurological complications. People can get seizures if you come off it too quickly. So engage with the alcohol cessation services, or go through your doctor. So of all the topics I want to cover in this channel, this one I feel optimistic about. We can make meaningful change. You know, it's not to downplay the addiction that people have, the difficulty that people have with alcohol. It is real. There's a big stigma attached with alcohol. I've done this long enough to know that it's not their fault. And I tell them, I tell families it's not their fault either. It's not helpful when you shout an alcoholic to try and get them to give up. But I understand how people are driven to that. You don't need expensive equipment to do this, but you do need help and support. And this is essentially what the science tells you. And I hope that this would be helpful for some people. If you don't drink heavily and you don't drink at all, and you've seen this, and you know people that do drink, and you think they could come off it, and you think it would be good for them, then quote the data, tell them, teach them. I've changed the minds of a few people and close to me, and I think it's been really good for them. I know people that tell me when they stopped drinking, they didn't realize it, but it really changed their lives. And so if you can spread the word, I think this video has been useful. I'm Dr. Cash Crypto. Thank you for watching. I'll see you in the next episode.